bad news is that you'll have to listen to me speak in English. The good news is that we're going to get a break right afterwards, so that'll be good. So my name is Robert Nieves. I am Vice President of Health Informatics for Elsevier. Professionally, I'm a nurse by background. I've been doing healthcare for about 28 years now, 29 years. As a nurse, I started in critical care, did emergency room, did long-term care, and did home care as well, all in the US. About 17, 18 years ago, I started focusing on informatics. I started implementing electronic health record systems, or KISS, is that how you pronounce them? In the US with hospital organizations. So I started getting really interested in how technology can really help the clinicians make better decisions, which is what we're here about. 13 years ago, I joined Elsevier. I started working with the evidence-based solutions like care planning and order sets. And I'm going to talk a little bit about today the standardization of the physician order entry process. So there is a conflict of interest because I work for Elsevier. But one of the questions that I get all the time from groups that I present to is, does standardized order sets really work? What's the proof that they work? And I tend to smile inwardly because for me, the proof is all around us. It's almost every day. I travel a lot. I travel globally, 40 countries so far. And I go through the security a lot. I queue through security a lot. And when I spend a lot of time there, you start observing people as we go through that queue. And things that you observe, everybody wants to get through. The results that we want to achieve is getting through that queue as quickly as possible, right? That's the results that we're after. But if you sit back and you watch people, you see all kinds of people go through it in all different ways, right? You have the people that are on vacation and the way that they go through it. You have people that it's the first time and they don't know what they're doing. You have the business travelers that are constantly traveling, and we definitely want to get through it. So we all have a process that we go through, and depending on how we go through that line, we get the results that we want. But a lot of inconsistent results is what happens, right? What we see. What I try to prevent is this. When I go through the line, I want to get through as quickly as possible because I don't want to get in trouble and get tasered, right? Because there is a danger of that when you get frustrated and you're tired. So I have a process that I follow. There's a sequence of how I put my stuff in the conveyor belts, right, to get it through as quickly as possible so that when I'm on the other side, I can put everything away as quickly as possible and get through. I follow that process every single time I go through the security line. And I get the desired result that I want, right, which is this. I want to be in the plane, in first class, right, on my way to where I need to go. Now, that's my idealized desired result. The reality is that I'm traveling like this. But you get my point, right? The standardized result gets me where I need to be. Another example, right, of why it works is the safety record of the airline industry. Would you fly a plane that allowed the pilot and the flight attendants to pick and choose how they want to go through their safety list, right? Or if they want to do it or not, right? You wouldn't be flying that plane at all because of their safety issues, right? We wouldn't want this. We want to make sure, and the airline industry is proven for this, they follow a standardized safety checklist process, right? And they have great results. We have a great safety record. So another example that this really does work, right? But in healthcare, we have a problem, right? We cause harm to our patients. Preventable adverse events or medical errors are one of the highest causes of death, right, in our industry. And these numbers, these are US numbers, but if you look at it globally, you look at numbers, we have the same problem everywhere we go across the world. So as an informaticist, I tell people, first let's identify what the problems are and define the problems. And then we look at how do we use the solutions and create the solutions and design the solutions to answer to those problems. So adverse events are caused by these different types of errors, right? We have errors of omission, errors of commission, communication errors, context errors, right? Diagnostic errors. These are the types of errors that cause these preventable adverse events. An example of an error of commission is giving the wrong dose of medication because you can't read or you misinterpret what the physician wrote, right? And how often do we sit there trying to interpret handwriting and we make errors, right? So an error of commission. We also have errors of omission. This is where we forget to do an intervention or we don't do an intervention, right? So oftentimes we're under-delivering care to our patients because we're not doing the right level of care. And so these are errors of omission. And these are a little bit harder to study, right? Because if you don't do something, you don't document it, you don't report it. But the studies that I've done show that there are a number of interventions that we're missing, right? And this is across the whole clinical team, not just physicians. I work with the interdisciplinary team. And we're not ambulating the patient, we're not turning the patient, right? And we're causing harm to our patients. We also have to understand, right, as informaticists, as clinicians, as working in this area, we have to understand how we behave as humans, right? And what's causing some of the issues. And this is the way that humans behave, right? There's the skill-based performance, right? Once I learn how to do a skill, I go into autopilot mode, I master it, and I do it that way from now on, right? And inserting an IV is an example of this procedure, right? So we go into autopilot mode. But the danger with this is that as evidence changes and practice changes, we have to do the procedures in a different way, right? Or use different equipment, et cetera, right? But if we stick to that autopilot mode, and we always do it the way that we do it, we're going to cause harm to our patients, right? Another way that we behave is rule-based performance, right? We learn there's a rule that needs to be applied, and we follow that rule, and we get the results that we want. So an example of that is trying to figure out which antibiotic to give to a patient with community-acquired pneumonia, right? And what is the right antibiotic treatment? There's rules around that that we need to think about as we're ordering, so that we could give and document and prescribe the right medications. So that's rule-based behavior, an example of that. And then the third one is the knowledge base, right? We don't exactly know what's going on, and we have to, based on the information that we have, based on the knowledge that we have to figure it out, right? So this is how we behave. From a knowledge-based perspective, we've already talked about it a number of times. The amount of information that's coming out, that's being published, that scientific knowledge is growing and growing and growing. An example of that, just from a numbers perspective, is that 2 citations, right, are being added to Medline every minute. So the amount of information that's coming out is enormous, and we can't keep up with the amount of information that's coming out. So this leads to knowledge variability across the clinicians, right? It all depends on how good you are with staying current with the information that's being published. Oops. So I'm going to go to one of the TED questions to engage you. So most medical errors are the result of what type of error in behavior? See what you put in. Opinion-based, practice-based, skill-based. Almost there. Opinion-based, practice-based, that's the answer. The right answer for an organization that we worked with was rule-based errors. In fact, 80% of the errors that they had were because of rule-based errors, right? They weren't applying the right rules and following the right rules and prescribing the right treatments, right? So rule-based errors was a big issue with this organization, right? So we need to look at how do we impact, right, that variability? How do we decrease those inconsistent results and look at how do we change variability? But standardization tends to have a negative connotation, and some of you have, and previous to me, have spoken about, right, about that. When you talk about standardizing a process, especially with physicians, the immediate thought is, you're telling me what to do. It's cookie cutter medicine, right? And that's not what I'm about, right? But standardization, right, is not about that truly, right? If we look at it, there is that unexplained clinical variation. Getting that knowledge to the same level, right, is an important piece of this. And that's what we have to address. And we use tools, clinical decision support tools like order sets and protocols, clinical documentation, et cetera, to help and bring that information and that knowledge so that we're all playing at the same level, right? That we're all looking at the patient through the same understanding, right? And that's what we have to address in the solutions that we're implementing, right? That unexplained variation, that unexplained clinical variation. But there is good variation, there's necessary variation, right? And that comes down to the patient, right? Because we're all different. And so what treatment will work for me will not work for you, or you, right? And so we have to take that into account. And that's where the art of medicine, right? And the clinicians coming in impact this, right? And the patient values and the patient preferences. So there is good variability, it's not all bad. So our solutions need to look at how do we address the left-hand side, but we also have to look and make sure that we are taking the patient into account, right? And understand who that patient is, so that we achieve truly patient-centered care, minimize variability, and standardize our practices, right? So clinical decision support tools is a way of doing that, right? And we've talked about that a number of times here. I'm not going to go too much into the definition because we've defined clinical decision support. What I will say to you is that think about clinical decision support much more than just rules and alerts, right? Think about your workflows. Think about the tools that you're building into your systems. So things like order sets and protocols, your clinical documentation, your care planning, your documentation templates, all of those can be clinical decision support tools if you design and build them to be clinical decision support tools, right? If you are bringing information in and help to guide your clinicians. And also your reference information, right? Your sources of reference that you are also attaching that you can connect to your workflows so that your clinicians and your patients are going to reputable sources and getting information that way. So all of those are clinical decision support tools that you can embed within your electronic health record systems. Now, clinical decision support is really important. This is just the MRAM stages, right? HIMSS, it's a huge body that's has gone together and established criteria around getting to a paperless system, and there are stages to that. And clinical decision support is a critical component of these stages to achieve this certification. So if that's important to you as an organization, you need to have clinical decision support tools to support that. But let's think about how an order set or the order entry process can help achieve standardization and achieve a highly reliable way of taking care of our patients, right? Through a safety checklist. So an order set is basically a grouping of the most common orders that are done for a given condition. So in this example, it's for sepsis ICU, and you have the orders. So these are all the antibiotic medication orders. But an order set will have all different types of orders within them, or categories. So you have nursing orders, you have lab orders, you have radiology orders, you have medication orders. Again, the most frequently ordered items for that given condition. So what this does is that it makes life a lot easier for physicians. In my order entry process in a system, I can just go to the sets and select the orders that I want, initiate them, and they get processed. So efficiency is an important piece of this, right? We have to make life a lot more efficient for our clinicians if we really are going to achieve adoption of these electronic health systems, right? So by standardizing and identifying what are the most common orders for a given condition, you're creating now a tool, a safety checklist tool, for them to remind them of things they should be thinking about. It's not telling them what to order, it's having them a list of things to select from that, again, based on their clinical judgment and rationale, they will then determine what is best to order for that given patient, right? So the safety component, safety checklist component is an important piece. So you have those orders. Second question. Which is not a... Whoop.
Sorry, I'll just go through it.
Do you want to read it in German so that...
No, I have to select it.
Oh. So which is not a way in which order sets with CPOE or order entry improve quality of care? Which is not a way? See what the results are. Very good. It's coming correct. It doesn't correct mistakes, right? It doesn't do that. It does everything else, but it doesn't correct mistakes. We try to prevent mistakes by utilizing them, but it doesn't correct mistakes. So you're right. So how can an order set also be a clinical decision support tool? You know, it could be an efficient way of entering orders. It could also be a safety checklist to ensure that you don't forget to order. But how do we make it a clinical decision support? So some examples. The example that I talked to you a little bit earlier, with sepsis, the importance of the right antibiotic treatment is critical, right? And when you administer and how soon you administer your medications. So if you're pulling information, guidance, into your order set, now you're bringing information that helps me gain better knowledge, right? And your whole clinical team that's using this order sets with the same information, right? So now I can make the best decision or apply the right rule, because there could be the rules that are in there to tell you which medications to consider. So now I have a much richer, right, order set and a protocol that helps me make the decisions that I need to when I'm ordering, right from my order entry workflow, right? So in systems, I can go in, I can select the order, but I can also get this information to tell me what I need to consider, right? So much richer than just a plain order set for order entry to make it efficient. And that's what we usually, if you have order entry, order set functionality, we think about it just from an efficiency perspective. We don't think about it as a clinical decision support tool. The importance is also that you can also give, it's important to give them what they need to know, right, in a concise way, because I don't have time to go and read everything about sepsis to determine what's going on. So the information has to be done in a very concise way and provided in a concise way. But I also have the source links that could take me to the information, right, if I need to go deeper and understand more, right? So again, it brings more and more information, and I'm the one that chooses where to go as a clinician to get that information. Another example, and this is actually one with very recently, I was in Puerto Rico with one of my clients, and they had implemented order sets in the emergency room, and they were using order sets in the emergency room. And what we found was that for COPD patients, the physicians weren't prescribing the right oxygenation treatment with BiPAP, for BiPAP. And so the order sets actually have that information within them, right? They hadn't implemented the COPD order set just yet when they had gone live. But what we did was that we implemented it. Their physicians were having issues with ordering the right level of oxygenation and the use of BiPAP. And we implemented the order set with that information, and that was there to guide them, right? Again, they were making the decision as far as what they ordered, but they had the information now, and that helped them achieve better care in the emergency room setting, right? Using the COPD order set. So not just order entry efficiency, but information that was helping them and guiding them in the treatment, the right treatment for their patients. So think about order sets, right, as that safety checklist. It helps remind us, it makes my life easier to enter orders, but also think about it with the evidence, right, with that information that it's being provided, so that I'm making much better decisions as I am in my order entry workflow, as I am ordering for this patient. And we want to make sure that they are using this as a way to achieve and decrease that variability, right? It shouldn't be an option, just like pilots don't have the option of not doing that safety checklist, right? Thank you very much. That's what I have. Questions?
Thank you, Robert. Questions for Robert?
So the question is there a risk with using a standardized order set, right? I mean, I think I caught the intention of your question. So from an Elsevier perspective, when we author an order set, and we do have a team that authors the order sets as a starting point, those order sets are localized at the client level, at the hospital level. The hospital will review those order sets. We will localize them to their practice needs, right? And create the standard for the hospital. So that's the first, actually the second level of localization of that order set. The doctor at the patient level will localize it or individualize it based on the patient needs, right? So ultimately the physician is the one making the decision as to what they order. It doesn't, again, tell them what to do. It guides them, and they're the ones that are ordering based off of that. There isn't a danger because you're basically placing orders, if you will. And then I think I caught another kind of nuance. So you have a pneumonia or a COPD order set, but what happens before that diagnosis, right? Is that?
More than, let's say, you start with an order set, and then really something completely different happens.
Right.
Yeah,
the order set basically is there to give you, these are the common orders and the information for this condition. It's simply by selecting another order set that's more near to the condition that you're now dealing with, or there's general order sets as well. So it's depending on how you build them. But there isn't something that says this is it, right? It depends on the patient condition. Other questions?
Yes. Talking about personalized medicine, can be seen as some kind of contradiction to order sets, or let's say differently, the order sets have to be much more precise, or have to figure in much more options. Huh?
Yeah, this is actually a debate that you have with organizations, right? Because an order set, as you saw, can have a lot of orders, right? And some organizations say, you know what, we only want a very specific order set, and they take out a lot of the orders with them, right? But the more specific you get, then you're really gearing it towards a very specific group of patients, right? Which takes away from that. So what happens if this patient, none of this fits this other patient, right? So you have to work with organizations to find the balance when they're creating their order set to incorporate all those situations. So I say, as a rule of thumb, we need to look at the 80%, right? Does this order set cover 80% of the situations for the patients that you have as an organization, right? So your diabetic population. You're not going to create an order set that covers 100%. And you definitely don't want it so specific that it doesn't cover that 80%. So those are the discussions that we have when we are actually implementing these order sets at the organizational level. Other questions? I want a break.
Thanks a lot, Robert.
Thank you very much.
Before